Assalamu alaikum, friends. I am here with new topic today. It's one of the late complication of fracture. And second thing is it important for you in your final exam and in clinical practice. So to start with today's case, I have 10 years old male patient. He had fall about 2 weeks back. So patient is 10-year-old, fall while playing, and elbow injury about 2 weeks back. So what sort of treatment he has taken? He has taken treatment by bone setter and who did massage therapy to him. And now patient is having pain and stiffness. So the pain after 2 weeks of the fracture, it's not a common thing because pain should subside after 2 weeks. So stiffness also, it should resolve after 2 weeks because fracture, acute phase of the fracture already finished by end of 2 weeks. So here the pain and stiffness is there. So that will make you think of some inflammation going on at the fracture site. So this is nothing but your myositis ossificans. Myositis ossificans. So how will you define myositis ossificans? Myositis ossificans is reactive soft tissue bone. So not a normal bone, soft tissue bone forming process. The bone is forming in the soft tissue around the fracture site. It happens the following trauma to the soft tissues. So this is the definition of myositis ossificans. If you are asked only about myositis ossificans, it can be classified by two ways. One is myositis ossificans traumatica. It's a self-explanatory term, the myositis ossificans happening after trauma. Second type is myositis ossificans progressiva. Here, what is happening is without any presence of trauma or injury, patient is developing progressive ossification of the muscle tissue. So myositis ossificans traumatica, myositis ossificans progressiva. So what are the muscles which commonly get affected by myositis ossificans? So myositis ossificans, as I told, it is forming outside the proper bone in the soft tissue. So it happens in quadriceps, it happens in brachialis, it happens in gluteal muscle. So these are the muscles which are commonly affected in myositis ossificans. What is happening here is the other name for myositis ossificans is heterotropic ossificans because the ossification is happening at abnormal site. So it may be either due to the direct trauma to the soft tissue or indirect intramuscular hematoma. So direct trauma happens by fracture or after the surgeries around the hip or elbow, that is total hip or major surgeries around the elbow joint, or intramuscular hematoma following blunt injury. So there is no fracture in the second type or there is no bony injury in the second type, but patient is developing myositis ossificans. So these are the two common causes for patient to develop myositis ossificans. We move on to next slide. What is the pathogenesis here? So after the fracture or what, there is some soft tissue associated injury. So it happens in the muscles and the tendons. So what is happening is after the injury, mesenchymal cells getting released inside the hematoma. The fate of mesenchymal cell, when they are not stimulated, they get converted into adipocytes and they are not harmful. But if they get stimulus by mechanical stimulus, by pressure or anything, then they change themselves to osteoblast. So these osteoblasts are not forming inside the bony parameter. They are forming outside the bone tissue. So in the soft tissue. So the osteoblast, they later on converted into osteocytes and they form myositis ossificans. So, hope this is clear. So what is happening is after the injury, there is release of mesenchymal cells. The fate of normal mesenchymal cells is conversion to the adipose tissue, but they get stimulus of the bone like pressure or mobility like that, then they get converted into osteoblast and later on to osteocytes and forming myositis ossificans. So this is the zonal phenomena. So if you imagine the elbow joint, so there is hematoma here. So there are mesenchymal cells. So they start proliferating in the center and goes on moving towards the periphery. So in the center, so they form zones. So initially there is just fibrous tissue. Then over the period of time, there is osteoblast formation. So it's surrounded by irregular or woven bone-like thing here. Then over a certain period of time, this woven bone move further away and it get properly calcified and form the lamellar bone. So we have fibrous tissue in the center, woven bone in the middle, and on the outside, we have proper lamellar bone. This is how the zones appears in the myositis ossificans tissue. So we have fibrous tissue in the center, mature bone at the periphery of the lesion. This point is very important because this is the arrangement differs it from osteosarcoma. In osteosarcoma, what we have is we have center calcified zone, peripheral non-calcified zone. Whereas it is reverse in myositis ossificans, we have central non-ossified zone and peripheral calcified or ossified zone. So what are the symptoms of myositis ossificans? So as I told, patient will still have pain after the fracture, long time of the fracture, he still have tenderness and swelling. And as it is forming outside the joint, so it may block mechanically and causes decrease in the range of movement. So it happens not immediately after the fracture, maybe 2 to 3 weeks after the fracture. So it's a late complication of the fracture. Then pain and the size decreases as the tissue start maturing, and after that the pain disappears, but we can only find the mass. And this mass stops growing when acute phase goes off and it becomes firm. So this is, you can see the various stages. Here you can, if you try to mark it, there is so much of tissue here. So over the period of time, it condenses and it ossifies and it finally forms a myositis ossificans like this. So it is just causing mechanical blockage, but not cause any pain after maturation. So on physical examination, you have palpable soft tissue mass and there is restricted range of movement secondary to mechanical block by formation of myositis ossificans tissue. So what are the blood investigations? So these blood investigations come positive only in acute phase. Once acute phase is over and whole tissue get matured or ossified, all parameters returns to their baseline. So they are CRP and creatinine phosphokinase. One important marker is serum alkaline phosphatase. Why this is important is this is active. This is raised when the bone tissue is active. So when patient is in acute phase of myositis ossificans, the serum alkaline phosphatase is high. So if you are operating myositis ossificans, you need to first check alkaline phosphatase. You should not operate if alkaline phosphatase is raised. You need to wait till alkaline phosphatase become normal. When it becomes normal, you need to go for surgery. What happens if you operate when alkaline phosphatase is high? The chances of reossification or reformation of myositis ossificans is high. So this is one very important investigation you need to do before you plan surgery for myositis ossificans. Then other is X-ray. So as I told before, there is a zone phenomenon here. So this very important point because it was once asked in PGB. Zone phenomenon is seen in where, which disease? So it is seen in myositis ossificans. So what is the central zone? Central zone is unossified zone. Peripheral is ossified zone. And there is dotted wheel pattern is there, and late stage organized cortex will be there, and marrow space resembling the mature bone, as I told before. So MRI we do to differentiate it with other inflammatory lesions of the bone. The CT scan classical eggshell appearance will be there. So this is the eggshell here. The same way in the CT scan myositis ossificans, if you see, it is eggshell appearance on myositis or on CT scan in myositis ossificans. So here the points to remember is alkaline phosphatase is very important because if alkaline phosphatase is increased, that indicate that disease in active phase, you should not operate. You need to wait till alkaline phosphatase comes normal. Second thing is peripheral bone formation in there, and when compared to osteosarcoma where you have central bone formation. And in late state, it resembles like a adult bone or matured bone. CT scan, you have eggshell appearance in CT scan. Once you have diagnosed myositis ossificans, we need to, if you see histology, just it is repetition of the previous slide. We have peripheral lesion in the region and central region. So central region, as I told, they are immature, irregular cell. There is no calcification. We have only cartilaginous component, which is going to move in future towards the periphery and forming the new bone. Whereas peripheral region, we have mature trabeculae of the lamellar bone, woven bone, and calcification seen on X-ray. So if you see here, we have cartilage, here some types of woven bone, here we have lamellar bone. Here we have cartilage. So this is outer zone. So outer zone will have mature cell, whereas inner zone will have actively dividing cells or non-organized. So it is in reverse with osteosarcoma. And we won't find any cellular atypia, whereas we find cellular atypia in patient who is having osteosarcoma. So once you have diagnosed, you need to treat it. So how will you treat? First treatment is non-operative, or non-operative treatment is just targeting towards the increase in range of movement. So what we'll do, we'll first give rest for the acute phase to subside, then we can start active range of movement and activity modification. We should never do passive stretching movement. We should not advise physiotherapy in this one, because if you do it, it may cause more trauma to the muscle tissue and may further increases the chances of or progress of the myositis ossificans. So this passive stretching, this is physiotherapy is contraindicated in this one. Then other things what we need to, we can manage by giving medications. Medications, among the medication we have indomethacin, then naproxen. These are NSAIDs which decreases the myositis ossificans formation. Then we have bisphosphonates. And lastly, we can give radiotherapy. So radiotherapy is not commonly done. It is done in total hip replacement or total knee replacement or major surgeries around the shoulders where patients have high risk of developing myositis ossificans. So to brief, indomethacin, naproxen, bisphosphonate, and radiotherapy as a non-operative treatment. So then if the patient is having mechanical blockage like here, we need to go for excision of the myositis ossified tissue. So if a remain problem after it matures. So how will you find whether it is matured or not? Then you do alkaline phosphatase. Then mechanical blockage of the movement is an indication. So we should not operate in acute phase. One, alkaline phosphatase is high. Because if you operate in acute phase, the chances of patient developing recurrence of myositis ossificans is high. So this is all about myositis ossificans traumatica. There is one condition, as I mentioned before, it is myositis ossificans progressiva. Otherwise, it is called as fibrodysplasia ossificans progressiva. It is completely different from myositis ossificans traumatica, but as the name resembles that of myositis ossificans, we need to know what exactly it is. So it is autosomal dominant disorder. And there is a progressive calcification of the skeleton and of the soft tissue muscles all around. And mainly connective tissue muscle, every part of the body like muscles, ligaments, tendons are getting involved here. It is associated with deformity of the great toe at the birth. So deformity at the great toe and presence of ectopic ossification all along the muscles, tendons, ligament is a myositis ossificans progressiva, fibrodysplasia ossificans progressiva. So any minimal trauma or irritation or any stimulus results in formation of ossification. So this is very dreadful condition. There is no treatment available for it ideally, but if surgery is contraindicated here, if you operate, then patient will have myositis ossificans of bigger size. Bisphosphonates therapy, it's not very much help, but it is the only treatment option available for myositis ossificans progressiva. So here you can see the normal skeleton. This is ribcage along with the scapula. Then here is the attachment of the muscles. So all these muscles are getting ossified in myositis ossificans progressiva. So here finally patient will land up in respiratory distress due to paralysis or ossification of all accessory respiratory muscles, and finally death is due to respiratory failure. This is all about myositis ossificans progressiva. Then here one more thing I would like to mention is there is one condition called as pseudo-malignant myositis ossificans. I forgot to mention in the slide, it's pseudo-malignant malignant myositis ossificans. What is pseudo-malignant myositis ossificans? Here, due to some reason, after the head injury, there is excessive ossification without any trauma in head injury patient. So after head injury, so patient who have in coma or head injury, subdural hematoma, they are having spontaneous ossification. Yes, myositis ossificans. So this is called as pseudo-malignant. It's called pseudo-malignant myositis ossificans. It's called pseudo-malignant myositis ossificans. This is all about today's topic. Thank you.